The patient actually has to be terminally ill, and they need to have a prognosis or life expectancy of 6 months or less. So that's one aspect of this. The second aspect of this is that a physician needs to certify this terminal illness. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about hospice eligibility criteria. But first, if you like our content, please like, share, and subscribe. So, in the hospice industry, we have eligibility criteria. Just like in home health, the participation and billing criteria are going to be a little bit different. But with hospice, you really probably need somebody who's terminally ill to do the treatment. So it's a little more tied together than the home health one is, because hospice treatment is not the same as just like any rehabilitative treatment. At the same time, hospice is much more clear than home health eligibility criteria. There are very specific requirements. It's much more of a pass-fail. So it's going to be hard to not meet the criteria for a patient who is technically eligible. Whereas with home health, you could have a perfectly eligible patient if you're not documenting in this perfect, exact perfect way that they want. It's going to be really problematic and questionable if you're going to get paid or not. So with hospice, we have very specific criteria. And here they are. Number one, you need a certification of terminal illness. This breaks down into two kind of little details of it, or three little kind of subsections. This means one, the patient actually has to be terminally ill, and they need to have a prognosis or life expectancy of 6 months or less. So that's one aspect of this. The second aspect of this is that a physician needs to certify this terminal illness. They need to say, I certify that this patient is terminally ill. They have 6 months or less to live. This wording needs to be in there, or prognosis of 6 months or less, due to blah, 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 whatever the qualifying illness is. This needs to be done by the attending and physician and the medical director, which often in hospice is going to be the same person. So we can dive into this for one quick second and can go into nuance in a kind of different video or different topic. But long story short, when a patient goes into hospice care, they can choose to have their doctor, who's been their doctor, whatever, any doctor of their choosing, be their hospice physician. If that's the case, now you have all this care coursing through their physician and also the medical director. Or they can go, okay, I'm done with my doctor, just let your medical director be my attending. At that point, everything gets done through your company's medical director. There's some specific medical director we're assigning to them, and that's who manages the care. Somebody's got to manage the care. So it's their doctor or it's your doctor. So that's kind of how that goes. If they're choosing their doctor, both physicians need to certify the terminal illness. The attending physician certifies, your medical director kind of signs with them, something like that. If it's just your medical director, now we have one signature on it. Next kind of aspect of this, so they have to have a terminal illness, prognosis 6 months or less, some doctor has to certify the terminal illness, your medical director has to agree with that. And this certification needs to happen 15 days before the election of hospice or 2 days after. So this happens at both the election, the start of the benefit period, and at any recertification thereafter. It's the same time frame, 15 before, 2 days after. So next, this is a micro detail of that little thing. The signature for that from the doctor or doctors need to happen before the case is billed. So just a little detail that a lot of people miss, and like your ADR can fail over this. But with home health and hospice, we have 30 days to get orders signed back from the doctors. But for actually both things, you can't bill the claim unless all those orders are already signed back in your office. So then later when this thing gets ADR'd, if it gets ADR'd, if your billing date is before orders come in signed, this is going to be a problem in your ADR as well. But anyways, we've gone far off topic. So certification of terminal illness has these criteria. Patient has terminal illness, patient's prognosis 6 months or less, and there is a certification by a physician of this terminal illness that says patient has terminal illness, patient has prognosis 6 months or less. The terminal illness, like this, my opinion, is due to these factors. Cancer, stage 4, this, that, I don't know, whatever. Next is that the patient needs to elect hospice. So unlike other kind of healthcare treatments and things like that, programs, the patient needs to specifically elect hospice, which is different than the consents they sign. It's part of that form could be part of the various consents they sign, but the hospice election is specific and unique in that in electing hospice, the patient is foregoing all other curative treatment, because hospice is not curative, it's palliative. So all you're doing in hospice is what you're doing in hospice is you're making them feel comfortable in their last days, essentially. And so when they elect hospice, they are saying that I understand I have this diagnosis and this prognosis. I understand that I am very, very unlikely to get better. I'm not getting better. And that this is it. And I'm not going to pursue additional treatments that could be rehabilitative or curative, meaning like I'm not going to try to fix this. I succumb, and that's that. And the purpose of hospice is to just make the person comfortable. So they have to say yes to that. Once they say yes to that through hospice election, at that point, they can't seek any other, essentially other treatment is not covered by Medicare. Like the hospice is fully responsible for their full health care completely. Are there nuances? Are there exceptions? Are there little details? Yeah, sure. But this is generally what they're electing, what they're deciding when they are signing an election statement. Later, they can revoke that, but revoking that takes them out of the hospice program. So it's kind of like choose your lane. And lastly, they need to be under some kind of care plan. This is done by your IDG group and revisited every 2 weeks. It's 15 days, something like that. 14 days or 15 days. I forget the exact number of days. But anyways, they're revisiting and updating that care plan every 15 days. Long story short, there needs to be a care plan that's managed by an IDG group, interdisciplinary group. So let's talk about some common diagnoses for hospice. Of course, there's cancer, there's end-stage, anything end-stage, but cardiac, renal, liver disease, whatever, advanced dementia. I mean, it's going to be anything end of life. With the documentation principles of hospice, just like in home health, you want to constantly reestablish the eligibility criteria, essentially constantly prognosis. The certification, recertification of each benefit period has this recertification of the doctor, things like that. So again, you really want to make sure you're following these rules to ensure your claim payments. And one thing I really want to point out, especially somebody going into these industries, is that when your claim is reviewed, if it's denied at ADR, they request back the full claim amount. They don't care that you paid clinicians and maybe 30% of it was fine, but 70 was, I don't know. It's not like that. They want the money back. They don't care who you paid. They understand probably it's not all profit. So it's really worth understanding this stuff, because when you're not getting paid on claims, you go not back to zero, you go to negative. And your margin on this stuff, I don't know what the margin is by company, company to company, it's going to be different. It depends on how much administrative staff you have. It depends on what your clinicians charge and stuff like that. So company to company, it's different, but it's definitely not like such a margin that you can handle a large percent of claim denials. So you really want to get this stuff down right. And with hospice, especially, like, please take the time to learn this because it's pretty clear cut. Like there's not much like gray area. So for companies getting a lot of denials, it's probably that the patients are like teetering on the edge of eligibility, or they're straight up just not eligible and it's obvious. Of course, your documentation throughout the chart needs to support the claims of the certification of terminal illness and eligibility. If this patient you're saying is like, oh, like, okay, I know nobody writes like this, like 1 month prognosis or something, but like, let's say, you're saying this. But then in every documentation, they're like partying in the middle of I mean, obviously no one's going to write that, but like, you know what I mean? Like it's just not supporting that claim. Okay, now you're going to get denied at ADR and things like that. So you really want to just like really be familiar with this stuff and document, again, just like with home health, every single note from any discipline. You want to really justify your eligibility criteria every single time. This just leaves no room for error when you have an auditor. So that's that, hospice eligibility criteria. Again, my name is Mariam Treystman from the Home Health Consultant. And if you like our content, please like, share, and subscribe. Thank you.